Sorry. I realised I didn't include sound, so I'm just putting that back on. So, afternoon, everybody. Welcome to our first of our Healthier Together Champions Lunch and Learn sessions. We're focusing on oral health today. This was a topic that had been identified as a key priority through our Core 20+5 work. So we decided to offer this opportunity because there was a lot of people asking for further information around the topic as well. What I'm going to start with is just a quick overview of what we'll cover in the session, and then hand over to Ollie and Greg around oral health. So I'll just give a quick introduction to the network for those who might not be aware of the work that we do, and just give you that background in relation to where this work comes from, and also the opportunity to be able to join the network if you're interested. If you could just make sure your microphones are on silent, please, because we're just getting a little bit of feedback. So just to set the context, and I think for a lot of you, you'll all be aware of the challenges that we have in the North East and North Cumbria, and some of our statistics around the work that we obviously are doing to try and address those health inequalities for children and young people. And actually, children and young people make up 20% of our population. So we need to obviously focus our work into children and young people to ensure that we give them the best opportunities and the best outcomes. We have the highest levels of child poverty in England, and I know from your perspective, you will see that in your day-to-day work. There's been a lot of reduced resource to be able to obviously address the health inequalities in the child health outcomes. We've got the highest rates of childhood obesity in England, and I'm sure I don't really need to go into further detail around some of those outcomes. A lot of the work that we're trying to do is obviously overcome those challenges, and part of our Healthier Together Champions model was about working with our wider community, so voluntary and community sector organisation, education, to ensure that we're reaching those most underserved communities, and our parents and carers have access to support and advice. And a part of our work is really about how we utilise data to target to the most needed communities. So the network's focus, many of you may already be members, is that we have a shared vision around, we believe all children and young people should be given the opportunity to flourish and reach their potential and be advantaged by organisations working together. And the Healthier Together model is very much about that, about how we work with partners to really develop the model further and engage our communities. You can see there we've got a priority wheel, and I guess there'll be no kind of surprises to you there around those common themes of what we're working on to address. You can see mental health, childhood illnesses, family support, poverty, health promotion, that best start in life, and inequalities and access, and additional needs and vulnerabilities. And what the system wants us to do is very much about share good practice, drive work forward, and connect to expert groups. And part of this approach is about that expert groups being able to share their knowledge and learning with the wider organisations in the community. So this just gives you a flavour of some of the work we do. There's a lot of work around that wider learning and engagement, and also working with young people about young people's voice and ensuring they're at the centre of what we do. Some of our key focus and priorities of work is the Children and Young People's Transformation Programme, our Integration Centre, and our Q pilots across the region. Lots of work around tackling inequalities. You can see there our links with the poverty proofing work around introducing that into healthcare, our STAR initiative, and some of the work that we do around apprenticeship roles. This year as well, there's been a lot of focus on the Core 20+5 model for children, and we've developed a model that gives that kind of overarching lens through the North East and some of those challenges. You can see there that overlaid by things like positive mental well-being, healthy environment, best start in life, food insecurity, and family life. So I'm going to stop there. That just gives you kind of a little bit of the background and context, and I'm going to hand you over to Dr. Greg Taylor and Mr. Oliver Sumner. I'm using your full title there off there. So if you just tell me when to next slide, I'll happily just press that along to save you taking control. Is that okay?
Yeah.
Yeah, not a problem. Thanks, Laura.
So yeah, I'm Ollie. I'm a consultant in paediatric dentistry.
And I'm Greg, so one of the clinical lecturers, specialist, and trainee consultant, almost there in paediatric dentistry, both working at the dental hospital in Newcastle, but also in other parts of the region as well.
Thank you for giving up your time to come. And it's really nice to actually hear that lots of people wanted to find out more about oral health, because it's not something that we get asked to do a lot. So it's great to see lots of people here and that you want to come and kind of find out more. So I think if we move on. So why do teeth matter? If we
No, you're on accent.
move on again. So this slide is possibly a few years out of date, but the kind of trends and the point is still the same. A quarter of 5-year-olds have tooth decay, and in the northeast that's actually higher than the national average. And in those people that do have tooth decay, they tend to have at least a few teeth affected. It tends to be 3, 4, or 5. And actually, it's not uncommon to have 5-year-olds or even younger with 8 teeth affected, or we can both sit here and say that we've seen children 2, 3-year-old that have 20 decayed teeth. That's all of their baby teeth. The majority of this tooth decay in children that are under 6 is actually untreated. So there's a lot of there's a treatment need there that isn't being met. And it's one of the most common reasons for children to be admitted into hospital. And actually, between the ages of 6 to 10, an elective admission for dental extractions and general anaesthetic is the #1 cause for a child to be admitted to hospital. And this is essentially a preventable disease. So it takes up a huge amount of resource, it takes up a huge amount of money within the health system. Then next slide. And as well as taking up a lot of resource and a lot of money, it actually impacts on a lot of children as well. So it can cause children to miss school. So a quarter of children in a study in the Northwest had missed days off school because of having toothache and infection. That in the long run, if you have a child who is persistently taking time off school because they've got persistent infection, can start to impact on educational outcomes. They will also spend lots of time awake at night because anyone that's had toothache will probably know that it's a horrible feeling. It's probably one of the worst pains to have out of everything. You can't sleep at night, you can't eat, you're grumpy, you're fed up. And that for a young person will then start to impact their parents or their caregivers as well. So they become grumpy, they stop sleeping, and they have to take time off work to take their children to medical and dental appointments. So it starts to impact on a much wider level. Next slide. It also actually kind of impacts on children's emotional health and their mental health and their well-being. And so if we move away from younger children to teenagers, a third of kind of young adults of teenagers actually said that they're embarrassed to smile or laugh because of their teeth, and a fifth of them have difficulty eating. We know that dental decay is a kind of cumulative disease, so if you have it, you're stuck with the impact of that for life, whether that's having lots of fillings or actually whether it's having teeth taken out. So you're having teeth taken out at 12 and 15 years old, even front teeth, that's them gone, and they then have to live with that for life. So it's a huge kind of impact. And actually, like I said, in the northeast, the numbers are much higher. This is kind of a split from different parts of the northeast. Tends to be sort of south of the area. Teesside has one of the worst dental health in the region. And the numbers there for 3-year-olds and 5-year-olds, but it gives you a trend as well. So the blue bars are in 2020, red bars in 2022. There's actually been, from these figures, an increase in the amount of decay in young children in our region. There will be lots of reasons for that. It's not just kind of COVID and the pandemic and the lockdown, but decay is increasing and access to dental care seems to be decreasing as well. Next slide. Again, this just puts the Northeast into sort of national context. So England there is in the middle. Northeast, we're not quite the worst in the country. We are second worst, but our figures there are sort of roughly twice the national average. So as a kind of ICS, as a health system, we have a lot of decay, much worse than a lot of other areas. So, as I said, dental services in the Northeast, North Cumbria, access to dentistry is becoming a real problem nationally. Most of dentistry is carried out in a primary care setting by a general dentist, and this is just sort of high street dentist that will be familiar, I'm sure, to pretty much everyone in the audience. They will see people of all ages, lots of different things, but that is where the majority of all dentistry, including children, is carried out. Access is massively a challenge. You will have seen in the news, you probably might have experienced it yourself. It's really difficult to find a dentist at the moment for, again, a number of reasons. But that is, in the ideal model, that is where every child should have a general dentist that they go to see every 6 months for their checkups. If they needed a little bit of treatment, it should be possible to do it within that setting. If you are asked how do people get to find a dentist, at the moment they need a lot of luck and a lot of perseverance, but there is this website on the nhs.uk. Put your postcode in there, it will bring you up a list of local dentists with all their contact details, and at the moment it will kind of filter out those that are accepting new patients as well, which might leave you with a fairly small number of available dentists. Next slide, I think. So like I said, most may not be accepting new patients, but a lot of them will have a waiting list. So if you get a parent to ring up, they can ring, kind of register their details, and then they'll get a phone call at some point when the practice is ready to take on new patients. The alternative is to do kind of access a dentist privately, and that will be increasing, and a lot of private dentists will also see children. So that's your kind of everyday routine care. There are some children that will need care that is above and beyond that for any number of reasons. So that might be that they would really struggle to accept treatment in a primary care setting. So children with autism or other kind of neurodevelopmental disorders, behavioral needs. It might be that actually they need a lot of dental treatment and they need to have some sedation or even a general anaesthetic for their treatment, and they would end up coming into a hospital setting. Or it might be that there's something complicated about that child, about their teeth or about their medical background. They're quite complex, they're quite ill, they're quite unwell. That actually means that they need some kind of specialist input or specialist treatment provision. And across the region, if you click onto the next slide, please. Across the region, we're reasonably well served with sort of secondary care services that are mainly provided within local community dental services, and more kind of even more specialist within the hospital. So the stars there are kind of specialist areas. So the main kind of hub is here in Newcastle in the dental hospital, which is kind of stuck up on the end of Richardson Road, just past the RVI. But each of those different shaded areas then have a community dental service that is responsible for that area. Within Teesside, County Durham and Darlington and Northumberland, there are kind of specialists or consultants that feed into that service. Next bit. We're a fairly small workforce. These numbers might be slightly out, but we sort of 5 consultants that cover the entire area, 5 specialists, and then 9 kind of trainees or academic trainees. So quite a small number of people trying to provide a lot of service for a lot of people. These are the kind of local community dental services. So they're predominantly work across different clinics. They will link into a hospital site, seeing children that are more complex, whether that's, like I said, behavioural, medical, or dental. Next slide. What happens generally is someone refers them, and that's normally a dentist, but it can be a healthcare professional, can be a GP or a paediatrician, or can be pretty much anyone actually that is worried about a child's teeth. That referral, wherever it's gone, will get triaged, and the child generally will be offered an appointment for a full dental assessment and any treatment that they need, whether that's with some sedation or a general anaesthetic, and then a plan worked out for their kind of long-term needs, whether that's going to be routine care with a general dentist, routine care within a community setting, or kind of long-term follow-up within a specialist setting. And it would be aspirational. One day, hopefully, we'll have a regional referral system, but at the moment, it's a little bit higgledy-piggledy. Next slide. If someone wants to access urgent care, particularly while sort of routine care is a bit more of a challenge, there are a number of ways of doing this, so people do not have to suffer in silence. 111 is probably the easiest and the best way of doing that. They can offer advice on the telephone if that's appropriate. They can also signpost to various primary care dental services, and they can link into access appointments. So these are urgent slots within certain areas and certain practices or hospitals, and these will often be available for the same or the next day. There's a regional out of hours care for evenings and weekends that will cover very urgent things such as trauma, bleeding, or severe pain. And they can also link into our secondary care triage within the dental hospital as well. So I'm going to hand over for a minute.
So yeah, I think just to kind of take on what Ollie said there's obviously a lot of children in the region that have lots of problems from a dental point of view, most commonly dental decay. But it might be the case that actually in your settings, whether it's healthcare or educational settings, you might have children coming complaining of teeth to you or issues and problems with that. And I think sometimes it's just a bit of a good overview to provide a little bit of understanding of what we think is clinically the main condition. So also, but what is normal? Because what the hope is that we have this picture in the teeth here, so you can see a child in the dentitions. They've got their baby teeth here only. They're lovely, healthy and clean. They're white. They've got nice gums that are pink and healthy. There's no redness. There's no angriness. There's no kind of discoloration. So it looks to me like a nice, healthy, normal mouth. And then if you just move on to two more pictures, you can again see this in these adult sort of more mixed dentition of the child who's developing into that young adult. You might sometimes see the corners of the photograph in the bottom here where you've got a couple of things going on. There might be some crowding, for example. So these teeth are not abnormal. They're abnormal in their position, but they're still healthy and clean teeth. And there might be some considerations to people thinking, well, why are those gums not pink, for example? And that might be a concern raised, particularly if you've got children who are from any sort of ethnic minority or from asylum seeker, because that's just racial pigmentation of their gums. So again, it's healthy and normal to us, and it's part of that kind of natural makeup of that child. But in these four photographs, you can see here, these are lovely, healthy, clean teeth with no evidence of active disease. And that's what we would be hoping for at a population level as well as an individual level. Next slide, please. There are some situations, though, where even in these two photographs here, where children have really nice sort of teeth, you can see they're very clean, the gums are healthy, but they do have these little subtle marks on them, probably a little bit more prominent in the upper picture with those little white spots you can see, a little bit less so with that yellow sort of creamy region there. Again, this is a disease process, but it's not the common dental disease that's been caused by sugar, by diet, which we're going to come on to talk about. This is something that's happened during tooth development. This is something that as a specialist or as a general dental practitioner would be able to advise and provide input into support into whether to treat this sort of condition or not. And it might be that actually children are potentially psychically, socially and impacted by these teeth. And there's some really good evidence to back that up. And if you can manage them and manage them appropriately at the right time, you can improve that for patients in terms of their quality of life. Next slide, please. But this is something that we see all too often, unfortunately. This is a picture of just good old-fashioned dental decay, as they say. And as you can see, the difference from those pictures of those really healthy teeth before, where you've got the gums that are nice and pink and healthy, and these teeth, you can see that there's all that white brown sort of area of breakdown. And if you look quite closely, the distribution of this is in particularly different areas. So some are affecting the sort of the inside of the teeth, so between where the teeth meet. In most cases, they're all around that sort of gum aspect, often suggesting that brushing's not been optimal or that sort of decay has been broken down. Now, at this point, if you've got decay in certain levels, and depending on the age and the cooperation of the patient, there might be limited options available, such as a general anaesthetic to remove them if they're symptomatic or they're sore, or it might be actually that the decision's made to monitor these teeth and change and prevent. And why we think that's a suggestion is because actually, as a disease, dental decay is preventable, but it's also arrestable as well. It's a process that's a dynamic process that can flip and switch between being active and inactive, and there's methods and approaches that we can support to stop that process. Next slide, please. Next 3 pictures if you can, Laura, thanks. But you can see here there are some situations, though, where actually, even with the best will in the world, the decay is too extensive. That's beyond the point of doing some sort of operative procedure that can try and hold those teeth or maintain these teeth. And in some situations, we have to then make a decision, is it the right thing to take that tooth out for that child? And in these sort of 3 photographs at the bottom, you could sort of, to the layman, to the naked eye, to someone who's not dentally qualified, you'll be able to see that that is quite an impactful problem, quite a lot of teeth, quite destructive in terms of how much tooth loss. But in some circumstances, next picture please, we actually have teeth, as you can see here, where the teeth that are no more. These are just stumps that are left that this child unfortunately has through numerous sort of repeated episodes of this tooth breaking down because prevention hasn't been optimized. And unfortunately, sadly, as Ollie mentioned, that there's sometimes we see children up to 8, 10, 12 teeth on an average basis having teeth taken out. It's not that uncommon for us to actually remove every tooth in a child's head around the age of 3 or 4, that being all 20 primary baby teeth. So sadly, it is something we see quite a lot. And I think these photographs here just really highlight the spectrum of disease, that it can be relatively minimal, but it can also be very destructive. And that is very much a spectrum and continuum across the patients and your children you'll see in your setting. Next slide, please. So what is dental decay? You'll have obviously, some of you may have experienced this, some of you will know a bit about this, depending on if you're involved in toothbrushing programs or health education with educational settings, or if you work within a healthcare environment. But fundamentally, dental decay, as we said, is a preventable problem. On our teeth, we have the white sticky plaque, okay, which is basically covered in fullness of bacteria. And if we leave that bacteria in place and we feed that bacteria with sugars from our diet, it basically turns it into quite an acidic environment. And in turn, that acid then causes damage to that tooth surface and over time will develop into a hole. So you can see here there are multiple areas that we can almost block this pathway. We can almost block it by not feeding it with the sugars, so having sort of diets that are sort of much less in sugar in terms of how much we feed the bacteria, or we make it to the point that actually we remove the bacteria on a regular basis by toothbrushing twice a day. That effectively disruption of that biofilm, that bacteria, that plaque, just reduces the ability for those sugars and bacteria to cause the damage. Or ultimately, it might be the case that actually having things like fluoride varnish applications or preventative approaches, so like the sort of banana toffee gel that your kids or you might experience yourselves, that almost it kind of remineralizes that tooth and kind of almost does a little bit of undamage that's already been caused on that tooth surface. But you can see this perpetual cycle. That's a very easy thing to get into. And if you've got that child who's potentially not getting a dental regularly or not having optimal oral hygiene or optimal diet, it can cause dramatic problems quite quickly. Next slide, please. Now, that's saying that dental caries, just as the disease process, is relatively straightforward. But as with most things in health and in life, various things will cause this to be adopted and to be risk stratified, whether you're at a higher risk of having it or lower risk of having it. And again, I apologize for a slightly busy slide, but you can just see here there's lots of things that will impact, ranging from the social circumstances of that child, being in that vulnerable situation where they're homeless or asylum seeker or they're unable to access care on a regular basis, making that preventive hit not common. They might have that medical compromisation that Ollie was talking about, which makes it quite difficult for us to perform treatment, but actually it might be challenging for them to brush their teeth. They might be autistic, for example, and not really comply with the foaming of the toothpaste. They might have cerebral palsy and therefore actually not have the dexterity to clean their teeth properly. Or they might actually be intubated and peg fed to the issue that actually they cannot provide oral hygiene themselves and they rely entirely on carers. Or they might have some medications which are highly sugary. Or they might be in a situation where they're potentially an oncology patient, so sort of having lots of chemotherapy and cancer treatment, and actually lots of snacks are giving as praise, which yes will be supportive in terms of their morale, but actually is quite demonstrable damage to their teeth. There's obviously the sort of more common factors in an oral hygiene and oral mouth and a diet point of view, and we'll talk about this in a little bit more detail in a moment. Next slide, please. So ultimately, there's a bit of kind of a dilemma here, because yes, we can't necessarily cure dental disease, but we can manage it and we can do fillings and we can take teeth out. And you can see here this sort of infographic, there's lots of methods and there's lots of stones that actually can do that. However, the prevention aspect of it far outweighs the kind of curative options. This is a preventable problem that as a society we can support and we can help these children and indeed adults as well with this. And if you look at just the comparison of the number of rocks there, actually prevention is a very small thing to do, but it makes a massive difference in terms of the dental disease of these populations. Next slide. So I'm going to focus in the next two slides then about really the main things that you can do to support or you can be asked to support. One of the things is clearly brushing your teeth. It's a relatively sort of privileged thing that we in our sort of circumstances will do on a regular basis. But for a lot of parents and children who may have not had the education or have the oral health literacy, they might not actually understand the importance of doing this or indeed how to do it. So it's about making it relevant for these patients. It's about actually, if you are going to be demonstrating or supporting oral hygiene, there are things that you can do, kind of advocate that. The use of fluoride, for example, is one of the most important things. That fluoride has a massive impact on sort of arresting and reversing that sort of potential decay and stopping that process. Making sure that you brush the teeth optimal twice a day, importantly before bedtime. And it might be actually that you have parents coming in and you give this advice and they have no clue because there's so much availability of toothpaste out there. What is the right toothpaste? The most important thing is, as I said, there's the number of fluoride and the contents of fluoride. And on the back of any toothpaste packet, you'll have a number which reads 1450. That's the optimal number that you're looking for in terms of brushing. There are some other aids which might help with brushing to make it fun and relevant to engage children. So, for example, using the dinosaur dragon that we have here. Or there's apps for slightly older children. This app called Brush DJ is an actual app where it will pick 2 minutes of your music and will play the music for the exact time you need to brush your teeth, telling you at each aspect to move around every 30 seconds. Now, yes, there might be that some parents in sort of certain circumstances might be digitally excluded because of that, but it's just a supportive tool for parents who do have that option. Next slide, please. Ultimately, though, if we think about these children, when we talked about that dental decay, the most important thing that we can exclude and we can really make a difference is the diet. Because if you don't feed the bacteria sugars, the bacteria are not going to create the acid. So therefore, by actually making sure that the diet is optimized is something that can be a real benefit, particularly when we have lack of access as we currently have. So again, dietary options, making these things relevant, actually making it accountable for what's happening in that family life. And if parents or children ask you to support, it's about making healthy choices, which having worked with a lot of sort of food banks doing some research recently, it is a particularly challenging aspect. And I think there's certainly a real area to kind of improve upon that. But it's trying to give you messages that can actually make it important. So, for example, reducing sugary attacks to just meal times. Teeth can cope a lot better if you only have sugar hitting it 2 or 3 times a day, rather than having frequent snacks on a regular basis, making it 5, 6, 7 times. Those teeth are in a far more vulnerable situation. It might be actually that maybe certain circumstances and certain foods are, yes, optimal, but are not achievable. So it's minimizing those or maybe making sensible switches or suggestions that can be supportive to those parents. It might be using additional resources in sort of PHSE class times to sort of look at what is healthy from a dental point of view that is generally also healthy from a medical and general health point of view. And also giving that advice as well. So if you are going to be given advice, it's making sure that you are consistent and that you're regularly improving and making sure you're maintaining these little hits. As you can see from the photographs here, there's a couple of things that we would be quite commonly think are healthy foods. Those sort of fruits, the snacks, and those sort of yogurts. Yes, a lot of these things are absolutely fine, but there are lots of things that have hidden sugars in them. And again, that's being mindful about watching about what actually the sugar content is, which is why this food scanning app below, as you can see, is a really helpful free app that you can get to actually scan the barcode that tells you what the nutritional content. However, there are some things that are very obvious, as you can see, the Nutellas, the Coca-Colas, the sort of the breakfast snacks. Again, a lot of these things highly sugar, highly calorific, but also have lots of sugar content. So if you're having it on a regular basis, it's causing these issues. Next slide, please. But there are sometimes, as I said, there are situations where actually we might be able to do things for kids. So in certain circumstances, we can't prevent or arrest decay, we might want to do an intervention. And you might see some children coming into your class or to your healthcare setting, actually where they say, oh, they've got these pirate teeth or princess crowns on. And these particularly areas have these management strategies, have revolutionized the way that we manage kids' teeth, because these have all been put on with no injections, with no drilling, with no sort of local anesthetic, with nothing other than just cementing these crowns on over the teeth. And what's the purpose of this? Well, it seals that decay in. It means that those sugars within the diet cannot get to those bacteria, and therefore that bacteria isn't going to create. So there are ways that we can support patients, and there are these sort of opportunities, but it's about, if we identify decay, it's getting that early identification and appropriate signposting to make sure that we can do something before it gets to the point where these teeth are not restorable. Next slide. But in some circumstances, you might have children, as Ollie's mentioned earlier, kids may have time off school, kids may have time where actually there are lots of issues in terms of pain and infection and abscesses. And here are three sort of simple photographs here demonstrating what looks like a simple abscess. And there are children come in, they might need some pain relief, they might need support, they might need to have treatment. So if you were to observe this, or a child would say, I've got a sore tooth, if you recognise this sort of splodgy sort of gum aspect, gum boil, it is the fact that this tooth is dead and infected, and there's something needs to be done about that. Because unless you remove the source of the infection, it isn't going to sort itself out. Next slide. I'm just going to put a couple of, Ollie and I just put a couple of extra pictures in here just to kind of almost talk about another condition which we see a lot in children. So we've talked very much about dental decay, but there's a lot of children that you will see probably have really shortened teeth or very glossy teeth where they actually wear them quite a bit. It's a really common thing in pediatric populations in children, more so in children who've got additional learning difficulties because they tend to sort of chew or grind on these things. There might be children who are nighttime grinders. If you've got children yourself, you might hear them chatting away at nighttime. And there's very little we can do to stop that really in this sort of area. And the good thing is they generally do grow out of it, although there are some sort of small population of that who will continue to have a kind of wear facet where they're kind of clenching and grinding. However, wear can also be caused by the diet. So acidic things in our diet, like fizzy drinks, like acidic, lots of acidic fruit juices, for example, on a more regular basis, can cause this sort of wear pattern as well. There are some children, though, who have reasons for erosion or acid from their stomach, sort of reflux disorders or some medical compromisation, which might cause that as well. And those are the sort of things that would be looking to liaise with either a dentist or specialist input. Next slide. But for completeness here, there are a couple of pictures we're just putting up here where this is where specialist input would come in. Now, it might be from looking at these pictures, you think to yourself, actually, these teeth are horrible, these children are not doing the right oral hygiene prevention. But in all of these circumstances, these kids have got healthy teeth that they are looking after. What has happened, though, is that the structure of these teeth, as you can see in those really pointed teeth, haven't developed properly. They might have a lot of additional teeth, as the picture in the middle there. You can see there's extra teeth and teeth are in the wrong position. You might have teeth on the right-hand side which are very intrinsically stained, and that could be because of a number of things, medication in childhood. It could be the fact that the child's had a kidney or liver problem, and as a result, during tooth development, it's caused that staining. Or you might have the photographs of the spectrum and the combination at the bottom here, where you have a genetic condition, where actually your enamel has just not formed properly because of an inherited condition from your parents. So you can see that there are circumstances here where, generally looking at it, that might be deemed that there's something not right, but these again are healthy teeth. However, in these circumstances, these would still need some requirement of management, and this is where reporting or referring in that system to a specialist and pediatric dentist would be important in this circumstance. Next slide, please. So just as we're coming to the last 5 minutes of this presentation, I thought it'd be quite important, Ollie and I, when we're putting this presentation together, just talking about children who've got special education needs and those who've got neurodevelopmental disorders or learning disabilities, because actually often you have to think out the box quite a bit for these patients. Because it's not just the conventional aspect that we can do. We can't just tell them to go and brush their teeth or give them that little bit of support that's required. And often the parents sometimes need a lot of additional support and might rely on you as an educator or healthcare professional to give them that. Sometimes it's really challenging to get children with neurodevelopmental disorders to the appointment. And actually having some preparatory information can be really helpful in terms of if they have additional sensitivities, if they have hearing issues, if they have issues with light or sound, that can be really helpful in terms of preparing them for that appointment. It might be that actually a lot of these children have real oral aversion or sensitivity. They might really have limited diets and very beige diets. They might eat only certain things, or they might really struggle with brushing. And there are some aspects here which we can support. So there's a toothpaste called Oranurse, which is predominantly for children with neurodevelopmental disability, where it lacks the component that foams up. So therefore, for those who've got oral aversion and sensitivity, it completely removes that. It's also bland in flavour, so therefore it's completely flavourless and odourless, which can be supportive. It might also be that actually these children need some ability to kind of tell us what the problem is. They might not have the capacity to communicate, and they might not necessarily be advocated for. So it's about kind of that challenge of trying to overcome what is the problem and what do we need to do for these children. And likewise, they might have some other situations where they might be kind of grinding or clenching their teeth, or they might be actually clutching at their faces, often an approach from a sensory aspect to tell them something's wrong. If they've increased their grinding or their clutching of their face, it might be they're identifying there is pain with this tooth, often a way you can identify. So is there that change of behaviour? And often a lot of these children, particularly who are autistic or particularly who have certain medications who are intubated or peg fed, for example, or long-term tracheostomy patients, they can often have really dry mouths either because of medication or because of the condition themselves. And that in turn kind of really causes problems with dental decay because that saliva is not there to help promote and heal the teeth, which it can do in a normal child. Next slide, please. So in addition to that, as you'll be well aware of in your settings, and we see it regularly, we can have the meltdowns of these children with neurodevelopmental disabilities, and it's really challenging. And it can range from things of having sensory overloads to the light, the noise, to a new environment, to just the fact of being in a dental chair. Next slide. But actually, it might also be the fact that they've been here before. They remember it. It's a painful environment, or it's something that stimulated them to have that meltdown. As I said, there are multiple things that we can help, and it's certainly you in preparing people to come to the dentist can support with that. There are storybooks. There's Makaton, for example, that can be supportive in terms of preparing people for the dentist. It might be that the pre-information that's given to us or can be supported. So, for example, what are they like in an educational setting? What don't they like? How can that be fed into supporting their care? It might be particularly timing is important. Some children may be better in the morning or the afternoon. And again, it might be the fact that they really like things in their school environment in the morning, but they might struggle in the afternoon. So trying to get it at the right time for them. Often is the biggest pain in our backsides can sometimes be parent and carers. They can be quite distracting and can be quite damaging, particularly with the language that they use, not just for NDD children, but in general. But in this particular cohort, they can actually be really helpful and supportive, and they really have to be engaged in the process because these are the sort of children that are not going to be able to look after themselves in terms of their oral hygiene. And in some situations, if in emergency circumstances, we might have to do a little bit of clinical holding in a supportive manner to make sure that we can identify if there are any problems. Next slide. So there are, next slide, other way. Sorry, Laura. That's it. But there are some sort of circumstances here that we can talk about that help with brushing. So we've talked about regular brushing and toothbrushes for children without NDD. But there are some circumstances here, so as you can see the photograph of this Dr. Barman's toothbrush, where actually it kind of brushes all 3 teeth at the same time. Is it as effective as a normal toothbrush? Probably not, because it may not have the same force to kind of get in there. But in these children where you may have only 30, 40 seconds of brushing, it's sufficient enough to clean it, to keep it nice, to get rid of that plaque and that bacteria, and almost use it as a tool to build the children up to a more regular toothbrush. Some children with NDD will love an electric toothbrush. They'll love the sort of vibration sensations. Others will absolutely hate it. And again, that's having that input and that discussion with those children and with those parents as to what will work for them. Next slide. But there's also, as I mentioned already, there's some sort of regular toothpastes that we've talked about here. But also there's also that Oronurse that I've mentioned. If we just go back very much to the diet component, I'm going to really hammer home the diet actually, because that is the kind of key thing here, as we've said. And it's exactly the same with children who've got special education needs. It's not necessarily about how much sugar's taken in. It's not necessarily the volume, it's the frequency of sugars. So we would often say with the children, it's far better to have a bar of chocolate with lunch than to have 5 pieces of that chocolate spread out through the day. There's also some important things about sort of making sure that there's no sugary hits or snacks 1 hour before bedtime, and actually making sure that if children do go to bed at night time, it's water in the bottle and it's not milk or any sugar drinks. Why is that? Because when you go to bed at night time, your mouth tends to dry up, and therefore that kind of capacity of the saliva to support that sort of healing and kind of keeping things calm just isn't there, and it can be really quite problematic. One of the biggest issues that we have, though, is certainly the sugar drinks in bottle, and particularly if these are going to bottles at bedtime. It just pools and pools and causes us lots of issues. We see loads of children in that very young age group where they have complete destruction of their teeth because that sugar in the drink is just sitting in there overnight, and that does include milk overnight. So it'd be the sort of thing we would be advising to have, if it is a bottle overnight, to reduce that to just water only. And this should be the situations, even with NDD children, to try and support them into that free-flowing cup. And in some circumstances that might not be feasible, but it's making sure that what is in that bottle, if that is the way, is important. Even things like juices, minimally as weak as you can, water is preferable. Next slide. As I've said, there's some things we've kind of talked about this already. So actually there might be the children who are non-verbal. They may not be able to describe that toothache, but they might actually start to show you that sort of stimming of that dental disease, that problem. Are they clutching at their faces? Are they suddenly behaviours changing, which is not normal to them? And you will see these children on a far regular basis than we will, as will their parents, but it's trying to pick up and identify. And it might be the fact of, is it pain because of a toothache, because of a hole, or is it the fact that actually they've just got teeth growing in and it's teething type pain? Again, that's where the support of the community dental services or the specialist services or the high street dentists can support children who have NDD. Next slide, please. So finally then, for the last sort of 2 or 3 slides here, as a kind of group who are obviously interested in coming to listen to this little talk from Ollie and I here, how can you help? We've obviously talked about some certain sort of circumstances there in terms of diet, in terms of oral hygiene, in terms of what to do with special education needs. But here are our kind of top 3 tips to take away. If you're going to support someone in reducing their oral health, reduce the amount of frequency of food and drinks that contain sugar is the optimum thing. That's what's going to make a big difference here. Second to that, it's supplementing brushing twice a day with that fluoride toothpaste, at least before night time and any other time during the day. There's also that sort of last caveat there about brushing, spit, don't rinse. There's often a misconception that you should rinse your tooth afterwards, with the mouth afterwards with some mouthwash or water. Actually, that's doing a complete disservice to your teeth. You want that fluoride to stay on there to help, and all you're doing is diluting it and washing that away. And lastly, it's about making sure that a child's taken to the dentist as soon as the tooth erupts, and encouraging them as much as they can. And I completely get that at the moment access issues can be really challenging and difficult, and you might have children saying, or parents coming and we can't get them into the dentist, what are we going to do? It's about encouraging them to optimize the prevention, and then if there does have to be a problem, we've hopefully suggested some signposting as we've mentioned earlier. Next slide. There's obviously some apps that we've talked about. So there's some public campaigns, Start for Life, the British Dental Association, and the British Society of Paediatric Dentistry all have lots of good oral health resources, as does the Healthier Together webpage. There's lots of oral health support resources in them. I've also put this slide in here about advocating, because actually I think as healthcare professionals, educational, or people who are involved in children, we have a real point, a real kind of almost moral obligation, I suppose, to advocate for a child's oral health. And that might be supporting them in terms of getting them into care. It might be helping and supporting through 111 applications. It might be even on a sort of more wider aspect, if, for example, public consultations for things like community water fluoridation or integration of supervised toothbrushing programs in school. These are all ways and methods that are relatively inexpensive and can have big impacts on children, particularly those from the sort of lower socioeconomic demographics, often whom have the highest burden of disease and the highest burden on the healthcare service for them. So there's a real point I would urge you to support and advocate these children. And finally, in the last slide, it is trying to encourage that dental attendance. There might be the circumstance where it is challenging and you have that, but it's in that sort of reinsurance and reinforcement that until the point where access potentially sorts itself out, it's about optimizing that prevention. And just as a final slide here, there's lots of resources available. So we've mentioned the Healthier Together webpage, which is excellent and is regularly updated. The British Society of Paediatric Dentistry has a lot of information on there, which is all freely accessible, as does the things like the British Dental Association as well. So thanks very much for listening. Hopefully that's giving a bit of an overview for you in terms of oral health, the kind of problems that it has, what we might see in terms of good oral health and more dental disease, but also some helpful and helpful tips to support the children that you come across on a regular basis. So thank you very much.
Thank you both. I'm just going to open up if anybody's got any questions they would like to ask while we've got this opportunity, the expertise. Anybody want to? If you just want to put your hand up, your virtual hand, or you can put them in the chat.
Michelle, yes, you can.
Yeah.
Yeah, there's the access to posters and leaflets. So, as I said,
Yeah.
the British Society of Paediatric Dentistry, you can print them off, Healthier Together. If you look on things like Aquafresh, Colgate, they all have patient resources, educational resources. There's also a couple of resources that have been developed through the University of Sheffield that actually I think has now been integrated into the educational curriculum plan about supporting supervised toothbrushing programs. Sort of, I can't remember the name of it. I think it's gone. Brush, that's it. If you just type into Brush into Google, Sheffield University, lots of resources there working with educational settings. So yeah, there's loads of stuff available there.
And we have got some QR code posters around oral health as well that we got developed as part of the Newcastle Food Bank work. So I know we have got some of those left over as well. If anybody is wanting some copies of those, we can get them out to you.
Yeah, they're really useful, Laura, and actually a lot of patients like it because it's that simple. Although there's that potential digital exclusion with those who don't have smartphones.
There is,
but actually,
yeah.
It's a nice simple way to get people around it.
And also, with the Healthier Together website, don't forget, you know, if they haven't got a smartphone, I guess as well, we can print PDF pages. So if schools have got kind of access to that print to give to parents to take home, then it's that other version of where you could give the information to parents as well.
There's a question about mouthwash. So generally, is it recommended? Probably not. Certainly wouldn't bother until a child sort of 8, 9, 10, getting to the point where they can properly rinse around the mouth and spit it all out without swallowing it. But generally, if you are brushing your teeth twice a day, every morning, every night, well, as in brushing them properly for 2 minutes with a fluoride toothpaste, there's no point in using mouthwash because, like Greg said, if you do it straight after you've brushed your teeth, you're just washing away a lot of fluoride. with a little bit, and that's assuming that there's fluoride in the mouthwash. So we will recommend it sometimes for children that we think are at very high risk. We'll give them an extra fluoride mouthwash to use at a different time of day. But in general terms, I would stick to just brushing well, effectively for 2 minutes twice a day, and leave the mouthwash. Don't buy it, it's just an extra expense.
And it's also, I think, as we've mentioned, that a lot of behaviour changes are actually quite difficult in making it achievable for parents. So actually, if you're having to then think about brushing twice a day with a fluoride toothpaste, reducing the dyes and then the mouthwash, it's that extra additional level that isn't going to give you much benefit compared to the sort of the benefit of just doing the kind of the basics right. So yeah, kind of echo what Ollie says there.
Is there any other questions anybody would like to ask?
We don't bite, excuse the pun.
Yeah, I know everybody's quite quiet, aren't they? Okay, yes, the slides will be shared, and obviously this is being recorded, so it'll be put up. The link will be put on the Healthier Together website, but we'll share the slides as well. Okay. So if there's
Can I ask a question?
Yeah,
Sorry.
of course you can.
Is there any plans to do any more sessions like this, just so I can let other colleagues know? Because I think it's been really good.
So do you mean another oral health session?
Yeah.
Yes, we are looking at a timetable, so we are pulling together. As part of this, we asked people what people wanted sessions on. So I think we probably will, if Greg and Ollie agree, that might do another session for us maybe later in the year, so we can catch people. We're going to have a full timetable because we've had quite a bit of kind of different asks of different topics as well. So we've just been getting some dates for kind of common childhood illnesses, epilepsy, asthma. So any topics that people want, if you tell us what people are interested in, because actually this is a great way of getting information out to community organisations who are supporting families, and I think that's where we really need to get the information to, because it's a lot of the voluntary sector particularly work with our most vulnerable families and are able to kind of share the information, and people when they've got that supportive worker or link worker in the community, they do tend to listen to those people and take on board the messaging. So yeah, we'll definitely try and arrange another date and get that out if people are agreed.
And Laura, just to take on that point, actually, we've with Emma and a few others have just done a lot of work integrating healthcare into community partnerships, like for example the food bank, and that was exactly that point that was raised, that actually a lot of the clients of the food bank and these community partnerships are not really that enamored by healthcare professionals coming into town, because they think they're going to get told off, they think they're going to get told the wrong thing, whereas actually that trusted community person that supports them on a regular basis is far, far important. So I know there is some work with Emma and ourselves so looking at kind of upskilling some of these community volunteers working in food banks and other partnerships to actually make them kind of oral health champions effectively, to provide this information, to provide that, but also to give them the basic knowledge of signposting. And certainly that I totally kind of echo what you've just said there.
Yeah, and I think obviously today I actually thought we would have got a lot more people attending, but I guess it's we've trained over 300 Healthier Together champions now, so we did distribute it out and it went through our network. So we did have a lot more people booked on than's actually attended. So it would be good to kind of maybe push it out again with a bit more notice of dates as well. I think after summer holidays and, a lot of people I know, particularly in schools, there's lots going on at this time of term around kind of leavers activities, assemblies. So yeah, I think if we can put something maybe, next term, or in the middle of term when it's maybe more accessible, and particularly, the time might be that we do a bit of a like early just after school. We normally sometimes do them when school days ended, because then staff have got a bit more opportunity to join as well around 3:30ish, if that's something that you could offer. Yeah, but we will definitely do another one. I think it's been to be fair, I found it very interesting myself as well, really informative. So one of the things we'll do is obviously we'll share all the links, we'll send all that, and we will we'll put all the information on Healthier Together as well, so people can access the videos around our learning sessions. So just Lynn, you've got your hand up, sorry, as well.
Yeah, I'm absolutely staggered. That's blown my mind about the state of the North East Children's Tea. What struck me though is, you know, when we are in the voluntary sector, we're a charity and work with families. But I think how do we get that message across? Yes, we've got masses of posters and leaflets and handouts for people, and yeah, I can approach those subjects with families because I've got good rapport with them. But it's a bigger problem, isn't it? You know, and you know, here you know, we'd take young people on residentials on days out. We don't allow them to have fizzy drinks. We provide water or juice, you know, diluted juice. So we're trying to do our bit, but then families will send their young people with carrier bags full of sweets, you know, and there we are providing them with healthy food when we're away. We're providing them with fresh fruit and vegetables and stuff like that. I think it's a massive undertaking, isn't it? Yeah, I'm just staggered by it all. But and I don't know how we get this message across. But also, one of my questions was, do you ever refer these children to safeguarding? Because for me, it is a massive issue.
Yeah, so funny you say that, Lynn. So just before we came on, actually, Ollie and I, we both talked about the kind of neglect point of view, and I think, Ollie, I'm happy to pitch in here when you think that the dental neglect is a really difficult, it's a very difficult threshold to cross. Because in terms of the kind of pressures and capacity that social services and social work and safeguarding teams have, often dental neglect in isolations doesn't always meet the threshold. To kind of put your mind at ease, yeah, we do liaise a lot with safeguarding, particularly if it's these children who have had the educational advice, the prevention support, and they're coming back with repeated disease, for example, or the fact that they've had a repeat general anaesthetic. These would sort of be triggers for us thinking that there's more of a potential dental neglect going on here. And it might be actually, as you said, that those social determinants of health and that wider aspect of, you know, I mean, food poverty, oral health poverty actually are contributing factors, irrespective if the parents are oral health literate or not. There is a lot of children, though, that actually dental disease is a bigger part of a safeguarding concern in terms of their wider, whether it be there's evidence of emotional or physical or social abuse, whatever it may be. So yeah, so we do see and liaise a lot with safeguarding. We also, within the hospital, we do any child who's sent for a medical health assessment as part of a kind of social services safeguarding referral. And we will do the dental health screening for them as well. So all of these children who are seen through social services and the RVI are seen by one of our team as a dental screen to check if they've got any outstanding dental needs and what needs to be done. And then there's an appropriate appointment put in place for those children to come back to the RVI, to kind of the hospital, to get a screening and to get the treatment necessary. So there is a kind of fail-safe approach to that there. But dental neglect is a really hard one to actually convince. I think in an ideal world, you could argue, because some people would say, well, if you've got one tooth that's causing pain, or you've got 12 teeth that are not causing pain, which is a problem? Well, you could argue both are, but which is more, and this is why you can't put an arbitrary figure on it. It's not like someone has an unexplained bruise on their face, for example. It's a little bit more hard, but there are definitely circumstances where we do. Would that be fair enough, Ollie?
Yeah, I think so, yeah. I was just going to pick up on your first point about, yeah, you're absolutely right. There is no reason why in this country, in 2024, there is so much dental decay in children when we know what causes it and it's preventable. I think there needs to be a political will to shift something, and there's too much cheap rubbish food available that's full of sugar, and people, for whatever reason, aren't brushing their teeth or looking after themselves and their teeth. So yeah, it needs to be more than just people kind of taking an interest sitting in this kind of setting and doing what they can. It needs to be much bigger. That's my little rant over. Otherwise, I'll go on.
Apologies,
I'm with
sorry.
you 100% because, you know, I see obesity, we see obesity every day. And I think, you know, when you've got a 3-year-old that is obese, you know, they're not making their own meals. You know, it's just so, it's distressing when you really care about children, isn't it? You know,
Yeah.
but yeah, we're going to all do our little bit, and that's what we're doing. So thanks very much for that.
So apologies, everybody. For some reason, my Wi-Fi decided to go off, so I've had a hotspot onto my phone. It's completely gone off, and I don't know why. But yeah, so that's why I disappeared for a couple of minutes. So I've missed all of that discussion there. Is there any other questions before we move on? We just have got a little bit of kind of updates on Healthier Together, the website, and what's been going on. A little bit sharing of some feedback we've had around kind of what people's been doing, and a chance to kind of discuss if anybody's got any, you know, updates or share any things they've been doing within their organisations as champions. So I'd like to thank Ollie and Greg today for their presentation, and we will get some dates sorted for another session, which we'll share out with colleagues in the future. We are getting them collated at the moment to get a programme together for the rest of the year, because we've had a lot of asks around different subjects, so we're going to try and get them all organised now before summer and get them out for the rest of the calendar year to help people plan their diaries as well. So a big thank you, it's been really helpful, thank you. So I'm going to just reshare my slides. Apologies because everything went off. And I realised at the beginning I didn't actually even introduce myself. So I'm Laura Cassidy, I'm the Network Delivery Manager, and I will have met some of you before on the Healthier Together Champions sessions when we initially delivered them. So I lead on Healthier Together website and mobile app and the Community Champions programme. So this just, we brought in a little bit of just to share some good news. We actually submitted the idea and concept of the project in relation to the Champions model as part of the HSJ Digital Awards around reducing health inequalities through digital, and we were actually winners of our category. So thanks to those who've submitted some case studies who supported that application, which I've shared in these slides. So it was really about showing how actually by working with, you know, the voluntary and community sector and our schools and education settings and wider partners, we can access the families and support them to access the, you know, the digital solutions that are out there, and obviously offer and ensure that there's wider information available that is if they haven't got digital access as well. So again, just to reiterate, Healthier Together, we know why we need it. We have 25% of our ED attendances are very much driven by children, and they make up, you know, a big kind of the pressures on our healthcare system around access and need and support. But a lot of that time is about parents just want to know when to stay at home, when to visit their GP, contact 111 or go to hospital. And that's what Healthier Together is about. It's about providing parents and carers and professionals with consistent information, advice to empower families to make informed decisions in healthcare. And I think a lot of the work we're doing, you know, we've worked with Greg and Ollie around trying to improve the information that's on the website, making sure it all links up with what, you know, the right guidelines are, and we are making sure that it's consistent. The Champions model was, we developed that, and it was very much about working with our partners and our wider communities to really get and share and encourage and support families to utilise Healthier Together. And I think, you know, this shows how this model can work by having these wider learning sessions, upskilling, and giving people the right advice that they can give to the families that they work with. So to date, we've actually, as I mentioned earlier, we've now trained over 300 Healthier Together champions within the voluntary community and education settings to reach the wider families and those communities that we know need access and support to access, whether that's access to services, whether it's access to information. And actually that's got a potential reach of 70,000 families, but we've still got a lot of work to do. Our geography is huge. We've got a lot of families to reach who are not still getting the information and advice and support that they need. So this is just to give you a little snippet of some of the examples we've had, and you know, Eva's Women Aid, working with women who are victims of domestic and abuse and sexual violence, and just that support it can give to a mum to give them the confidence to access services. So mum was concerned about her 8-year-old son who had been feeling poorly. She kept him off school and encouraged her. She'd been encouraged to download the app and check the symptoms, and it actually made mum feel relieved about, you know, she sent her son back to school, made a GP appointment, and actually was diagnosed with hay fever. Now, actually, it might seem, oh, you know, or some comments might be, oh, it's just hay fever, but actually hay fever can impact massively for children, you know, in relation to the symptoms that it gives, but it also can have that link and that exacerbation of things like asthma, if a child has asthma, or, you know, it's lots of different things. But her son hasn't missed any further days of school, and actually, you know, it made her more confident and she felt informed and known what to do. I'm just going to also share Newcastle Carers. They worked with their families around developing some little animations to promote it through the work that they do. So I'll just play this here. It's just a short These are some of the, just to give examples of what people have been doing, and we're just at the point of evaluating the new, waiting for a lot of feedback and evaluation for this term. So schools who've participated will be sending their kind of summaries of work back at the end of this term, because we'd looked at things like pre and post school attendance after they've promoted the Healthier Together resource. So there's lots of great work happening. So it was really just to kind of give you a little update and snippet of where we're at. These are some of the new pages that have been developed. They are links, so I will share them and I'll just go through. So we've got some new comms posters that have been developed, and if you were, some of our champions organisations will have received these as resource packs, because they were all the updated materials that we got done and that were posted out to organisations. We've got a new animation, which the links on there that you can share or use on your TV screens or wherever you've got, you know, parents might be there accessing or share on your social media. We've got some new pages for parents and carers. We've got a tracheostomy page, which we've developed with Newcastle Hospitals. This is focused just for parents whose children obviously have tracheostomies, to show them. So now, you know, instead of utilising so many or leaflets, there's lots that can actually send them messages directly to their phones. We've got the new page on Intwin and Pigeon Twin, so things about, you know, things that parents probably, you know, just need sometimes that bit of advice and information. Chest pain following a head injury, and I don't even know if I can actually pronounce that one. That's very technical. So yeah, and then we've got some professionals pages that have been updated. Just to highlight there, we've got our Beat Asthma Friendly Schools pages, which I probably mentioned when we did our champion sessions, but we've also got a page for sports clubs as well. So if you've run anything around becoming an asthma friendly sports club, or if you've got clubs going on in your organisation, you know, we really need to impact and support our families with children of asthma, because we still have, you know, children unfortunately today in this country dying of asthma, and actually it is something that could be preventable if it's managed effectively and given the right support. So lots of new pages, always ongoing. We're always trying to get new content when people ask us what they would like on, and when professionals, but, you know, from a community perspective, if there's things you'd like to see developed or improved, please do let us know. So just to give you a bit of impact, we've got on the website now to date, we've had over 245,000 users. We've still got quite low uptake on the app for our size of our region, so we really need to push that uptake around families downloading the app. And I know different parents prefer either websites, apps. We've got differences in opinion around that, but actually what we do know is 2/3 of those children who use the app end up in the self-care disposition, so it actually can have an impact, because actually it means more families are managing their children at home when it's appropriate. Just obviously we've upskilled working with yourselves to signpost families to the resource, and it's very much, we've worked with some schools where we've got that feedback where it has improved for some children, their attendance, where parents are using it for that low level common childhood illnesses where there'd be kind of anxiety there around sending their children to school. And it's really about that increased parental confidence, and that's some of the feedback we're getting from organisations around parents telling them they feel more confident when they use the app. We are monitoring our ED attendances around this, and we've looked at comparison data for 22-23. We're still obviously, this was in year, so it was full year data. It wasn't financial year because of the time we got this data. We've actually seen an 8% reduction in children's ED attendances and 4% reduction in 0 to 18 years. And actually, you know, we would hope that a lot of the work we're doing around Healthier Together and other, you know, work that's going on is so attributable to this work, because actually it's a harder one to kind of just say it's solely attributable to, but we would like to take a little bit of that in relation to the work that we've been doing, because we have been driving this forward across the region and pushing that. And a lot of the hospitals do share the resource with the parents when they attend ED as well. So just around future sessions, from your feedback, this is the kind of themes that we got. Just to let you know, we have already got some planned, and the dates will be released in the next coming week or so in relation to being able to book spaces. So we've had things around, obviously, neurodevelopment, was an area around learning disabilities, difficulties getting a diagnosis, autism and ADHD support. We've got a lot around mental health and well-being, nutrition, long-term conditions. So we will be looking at these, and we'll be planning kind of the schedule on based on your feedback as well. So it'd be great if anybody's got any other topics they think would be beneficial, particularly to your organisations in the community. So this is just really to open up to yourselves around if there's any kind of views, want to flag anything you've been doing differently or want to share, or just any questions really, I guess. Anybody got anything? I'll open up the chat, or if anybody wants to put their hands up. And everybody's gone quiet again on us. Anything from anybody? Julie, you've got your hand up.
It was just to say thank you for the session. It was absolutely brilliant, really, really helpful. I'm the Oral Health Promotion Coordinator for Newcastle Hospitals as part of our community dental service. So it's just to say I'm really interested to find out more about what the Healthier Together champions are.
Yeah.
So I might do that kind of off here because I don't want to take over. But it all sounds absolutely brilliant, and hopefully I can get involved and support. But I will be working with key areas, supporting the likes of the underserved communities. I've been working with like the health visitors, school nurses, voluntary community sector for sort of 0 to 19, older people, those with additional needs, homeless, asylum seekers, and so on. So yeah.
Great.
So
no, I know, but if you want to drop us an email,
Great. Thank you.
No, that'd be brilliant. Is anybody else got any questions or anything they would like to ask? No, everybody. Oh well. Thank you for attending. Just a reminder, if you're not a member of the Child Health and Wellbeing Network, you could join. The links are in these slides. I will share them. There's lots of other things around getting involved. So if you facilitate engagement with children and young people, we do have a kind of networks for professionals and for our youth voice. So we have a youth board who do a lot of work, who've just developed a manifesto about how young people should be engaged with health and have a voice. And actually one of those things is that we want more broader networks who we can link up to as part of our work to get that youth voice broader across the North East North Cumbria footprint. So we're always keen to get people to sign up to that as well. I've just seen Patsy's that we are delivering a peer support project with primary schools in North Tyneside. We have lots of parents worrying about mental health support for SEN children, anxiety, and any sessions on this would be brilliant. Yeah, Patsy, I'll note that down, as I think we've got that on some of our on some of the feedback from yourselves as well. So we'll look into that and see who we can get engaged to kind of deliver those sessions as well. Brilliant. Well, thank you very much, everybody. I will share the slides out and we will be posting the video link as well. Thank you for coming and hope you've enjoyed the session.
Thank you.
Thank you.
Bye.
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 Thank you.
Thank you.